and go in the cardiology as such. I always say that after IT, if there is any science which has progressed miles and miles, is a cardiology. If you take interventional cardiology, there are various devices, various evolutions in the strains has occurred. And as far as the pharmacology is concerned, we are way ahead in last 3-4 decades than what we were in the past. Thrombolytics, antiplatelets, direct oral anticoagulant agents, something like heart failure management in the form of ERNI, in the form of DAPA. I always like to go into the details of these studies and trials when the molecules are taking birth. It's very interesting to go through the journey of these molecules, and you can click from your insight that this molecule is a particular molecule which is going to hit a lot in future. We predicted it for prasugrel, we predicted it for ticagrelor, we predicted it for ERNI, we predicted it for DAPA. The same thing, that prediction is there for Cangrelor. As Dr. Sathe sir has told you that he has delivered lecture 10 years back. Yes, in 2009, the first trial of this Cangrelor was there, which was held in US and which was done in US by PI, Dr. Deepak Bhatt at Massachusetts. And it was in one of the hospital, thousands and thousands patients were enrolled. Somehow that molecule didn't get USFDA approval, though the data was favoring, but the primary endpoints were not met. So this molecule didn't get an USFDA approval. On 22nd of June 2015, Cangrelor got an USFDA approval. And this USFDA approval is for as an antiplatelet agent. And if you go to the history, what are the weapons in which we can deal with our strongest enemy, thrombus, clot? Thrombus is the biggest enemy of a cardiologist. And what are the weapons in our hand? Antiplatelets, anticoagulants, and fibrinolytics. Among the antiplatelets, we have aspirin, which is the cheap, easily available, age-old therapy, which works for approximately 25% of the platelets by irreversibly acetylating the COX-1 pathway. So we all know that aspirin is inhibiting the thromboxane A2 pathway, and that works for nullifying approximately 25% of the platelets. We are using clopidogrel for more than 2 decades now, and we are happy with that molecule. With knowing there are various issues with clopidogrel, particularly in the Indian, patients. We have seen clopidogrel resistant patient, hyporesponder patient, stent thrombosis with clopidogrel. So there was a continuous ongoing research which was going on, and that research was to some extent fulfilled by prasugrel, with a lot of drawbacks of prasugrel. And then the ticagrelor molecule came into the market. Prasugrel, ticagrelor, clopidogrel, they are all, they are P2Y12 inhibitors. Clopidogrel and prasugrel, they are prodrug. Like prodrug means they have to pass through the intestine, from intestine to the liver, and there has to have metabolism into the liver, and then it goes into the systemic circulation to nullify the platelets. So there is a two pathways there, and by this way that prodrug acts, and that's why this is little less to begin with. It is onset of action is little delayed. Ticagrelor is something which was new in last 5-6 years. We are using right and left this molecule as and when indicated, as and when permitted, particularly in acute coronary syndrome, STEMI, non-STEMI patients, long stents, left main bifurcation, complex angioplasties, multiple overlapping stents. And we are happy with this molecule with some of the limitations. Little increased bleeding tendency, though the p-value is not significant in the studies. Some side effects like dyspnea, some of them they are getting dry cough, some of them getting for transient periods, some ventricular, some pauses, sinus pauses. So, but otherwise we were happy with ticagrelor. The issue is now we were using ticlopidine. Dr. Sathe sir will agree with me that previously our angioplasty patients in 1995 to 1999, they used to get discharged with aspirin and ticlopidine with full fear of side effects of ticlopidine. We used to call the patients after 2 weeks from long places from Yavatmal, Chandrapur to see what happens to their CBC and what happens to the LFT. This molecule is now, we are not using this molecule. Dipyridamole is exclusively not used in coronary practice. It is used by neurologists in TIAs, recurrent TIAs, to prevent stroke along with aspirin in an extended formulation, which is a phosphodiesterase inhibitor, limited value there also, and not much used in coronaries. GP blockers, we used GP blockers vigorously from 1996, 95 to maybe till today, 2015, 16. Now, these molecules, the need of this molecule is nowadays remaining as a bailout thing only, because apixaban is a purely cardiologist baby. So it was not been used by physicians, not used by clinical cardiologists. Iptifibatide and tirofiban, the indications were there, but now we are having potent antiplatelet agent, newer generation stents, early acting molecules. So the need of GP blocker is now remaining as a bailout procedure. GP blockers act at the glycoprotein GP2B3A receptors, ticagrelor, ticlopidine, clopidogrel, they act at the P2 white whale receptor, and aspirin, as I discussed with you, is a COX-1 inhibitor. This is like, when we are discussing about the antiplatelets, we must understand the basic hematology. You can say the basic physiology of the thrombus formation. When we are dealing with arterial thrombus is a white thrombus. Arterial thrombus contains more of a platelet, less of a fibrin. So there is a need of aspirin. There is a need of another antiplatelet, which is equally potent than or more potent than aspirin, because we have to block at least two pathways for deactivating the angry platelets, which is the crux of the thrombus. So whenever we are dealing with the arterial thrombus, we need more of an antiplatelet. In the initial phases, anticoagulation, heparin, conventional heparin, bivalirudin in the cath lab, or fondaforinux. But when we are dealing with the venous thrombus, deep venous thrombosis, systemic pulmonary, this venous thrombosis, there we need more of anticoagulant, because these thrombi are less of a platelets, they are more of a fibrin. So here we need anticoagulants, and there is a less need of antiplatelets. In acute coronary syndrome, we need more of an antiplatelet. To some extent, in the initial phases, heparin analogs or heparin, and in ST elevation MI, if primary angioplasty is not possible, we need a fibrin degrading agents like streptokinase or tissue plasminogen activator derivatives. So these are the weapons which are available to us as far as the managing the thrombus is concerned. The bright age of this dark COVID cloud is now we are more wiser after this COVID pandemic. We started doing a lot of things about the thrombus, because we are now seeing more thrombotic complications after COVID, and to some extent after COVID vaccination also, to a small extent. So we are now more wiser, and we are now using more often these DOACs than what we were using in the past. And now when we take the patient for angioplasty, primary angioplasty, early angioplasty, or an sick patient with non-STMI with hemodynamic compromises, we always see that we tend to load the patient whichever is available with us. Mostly we crush the ticagrelor in the casualty or in the CCU with aspirin and take the patient for primary angioplasty. This is a nice picture which is described by Michael Gibson, that this is the patient which is a case of post open heart surgery and taken for a primary angioplasty, and what he has seen is the tablets which are still undissolved, and his angioplasty is over, artery is flowing well, still the tablets are still there in the stomach. So these tablets have not passed the intestine, they have not crossed the hepatic metabolism, and the antiplatelet action of the potent antiplatelet agents has not reached to the bloodstream. That means the platelets are still activated. If the platelets are still activated, then you are inserting a foreign body, no matter how good the stent is, but it is a foreign material. No matter which is the metal, which is the drug, or which is the polymer. But if the foreign body is inserted and you are inserting it into the thrombotic environment where the fissured or ruptured plaque is there, the this intimal matrix is exposed to the bloodstream, there is activated platelets, there is a thrombus, there are fibrin threads, there is activated Wall-Willebrand and all those factors cascade is there, and in that scenario you are inserting a stent. And where are your antiplatelet agents? They are still in the stomach. because that has not dissolved and that has not gone into the liver and that is not metabolized from that side. So we need to bridge this gap of onset of action in an emergency situation or in a primary angioplasty where we want to have an adequate antiplatelet action. Why this is important? You say you are giving heparin, you have given other molecule, and you will be using thrombus aspiration catheter, which is also now downgraded in the list of management of acute coronary syndrome as per the European Society or American College of Cardiology guidelines are concerned. But whatever said and done, you have to nullify the platelets which are angry. And there are various issues when patient is intubated, ventilated. Not an uncommonly, we see that patients coming with an acute coronary syndrome and myocardial infarction because of vomiting. Vomiting, we know the various mechanisms of vomiting in acute myocardial infarction. Patient is vomiting, so even if you have given the tablet, there is a chance that those tablets will be vomited out, or you are afraid of giving those tablets as patient is vomiting. And till today, till the availability of the Cangrelor, there was no such intravenous antiplatelet molecule which was available. Whatever was available was a GP blocker in that situation. Patient with cardiogenic shock. What happens in cardiogenic shock? Patient systolic blood pressures are low, systemic circulation is slow flowing. There is a lot of issues as far as the GI congestion is concerned. The absorption of the molecule from the intestine, its metabolism from the liver, everything is hampered because of the cardiogenic shock. So you are not sure about the antiplatelet action of these P2Y12 inhibitors. Patient could be heavily sedated, so it is not possible for patients to give antiplatelets to that patient. There could be therapeutic hypothermia, and all these things together make that patient, that patient receiving antiplatelet agents and having that antiplatelet action on the board is theoretically very less. These are the various studies. These studies, they are there for acute coronary syndrome, and these are the studies for STEMI, where the time of preloading of the antiplatelet drugs were, discussed in these various studies. And these studies have clearly mentioned that previously, you might be knowing, STEMI was considered as something which needs to be immediately attended way back in 2000 and late part of 1990s, or non-STEMI we used to manage with low molecular weight heparin, aspirin, and whatever available antiplatelet agent, and then after stabilizing the patient, then take the patient to the cath lab. But those were the old days. Now we know that earlier is the better, and these are the studies and trials which have showed that there is, door to balloon time, or you can say when we are dealing with the door to balloon time, lesser the better. We have to have the antiplatelet drugs loaded earlier. So ticagrelor or prasugrel in STEMI, we always tend to achieve door to balloon time. In our National Intervention Council, we always have to submit the data of our center where we have to mention how many PAMIs we have done and what was the door to balloon time, an average door to balloon time. As per the NABH protocol, our institute is also very strict, and we also need to keep the data right from door to balloon time, means arrival into the casualty to the taken to the cath lab. And we must always achieve less than 60 minutes of time, try and achieve it. So what happens in those 60 minutes of time? Yes, patient reached casualty, you have crushed the tablet, you have put an angiocath, screened the echo rapidly, called your cath lab members, taken the patient into the cath lab, and you did take the patient to the cath lab, did the angio, opened the vessel, 1 hour is over. Where is the platelet reactivity? Look at the platelet reactive unit of clopidogrel as well as prasugrel. It is tending to 0%. Prasugrel starts its action at the end of 2 years, and it peaks its action at the end of 6 years. Clopidogrel even after that. So when we are taking this patient so fast and so rapidly, this is not to make the NABH or make the National Interventional Council happy or not ourselves happy. We want to open up the artery as early as possible to save the myocardium. If the purpose of saving the myocardium is achieved, and if it is achieved with non-deactivated platelets, then there could be chance of having stent thrombosis in such patients, or event rate in the such patients. Low flow, slow flow, no flow in during the primary angioplasties when less potent molecules or delayed loading of such molecules is done is not an uncommon thing. And then you tend to do so many things and patient's hemodynamics start deteriorating. You tend to, the patients start having arrhythmias, patients start having VT, hypotension. You tend to put in on inotropes. You tend to inject adenosine or diltiazem in the systemic circulation. You use the thrombus aspiration catheter, put the microcatheter into the distal circulation, inject there the vasodilator, and by that time, myocardium starts damaging. More the myocardium damage, more the less the long-term survival is there. So this is the wonderful graph of pharmacodynamic and pharmacokinetics of prasugrel and ticagrelor, and the platelet reactivity unit, if you say less than 300 is considered, then it starts after 4 hours or 2 to 4 hours or so. So we need to have something to bridge this gap. If we are dealing properly with the door to balloon time, proper medication should be there. What can we do for that? Number one, early administration. Yes, early administration is possible with clopidogrel, possible with ticagrelor. It is not possible with prasugrel because unless you know the coronary anatomy, you cannot load the patient with prasugrel. So prasugrel is out of question. Patient is in casualty, and you want to take him from primary angioplasty. Our duty officer is discussing with the relatives. So we need to early administer. We have administered aspirin, we have administered clopidogrel. Action of clopidogrel will come after 6 hours, 4 hours, or 8 hours or so. Even if you load with 600 milligram, not earlier than 4 hours. If you crush the ticagrelor and give aspirin to the patient, action will come 30 to 60 minutes after crushed tablet of ticagrelor. So that is the issue, and you are planning for an angioplasty within 30 minutes. So early administration to some extent benefit, not to major extent. High loading dose. 300 can be increased to 600, but 60 milligram of prasugrel cannot be increased to 120, or 90 milligram of ticagrelor cannot be increased to 180. So high loading dose to some extent is true with clopidogrel. Some benefit, marginal benefit in some of the studies. Some of the studies said it is intuitive. Giving crushed formulation, yes, we crush aspirin, we crush ticagrelor, we give them. Then what is remaining in our hand till to date? It was the GP blocker, which was the bailout thing, which was remained in our hand. What we used to do, we used to give aspirin, we used to give ticagrelor crushed form, take the patient to the cath lab, do the angiogram, look into the thrombus, and then decide on table whether to load with bolus dose of tirofiban or eptifibatide, and then give subsequent infusion, because these were the things which were in our hand. If the thrombus was not very large, not very obvious, then crush it with the balloon and stent it, and SOS add GP blocker if required, if there is a slow flow or no flow in that situation. Or if the thrombus is less, then just forget about it, wait for the ticagrelor to action to come, and keep your fingers crossed for the next 2 hours or 1 hour till the action comes. Now we have something which is wonderful thing which is in our hand, that is the Cangrelor, where immediately you start this molecule by giving a bolus dose, and action starts within few minutes. Cangrelor is an IV bolus followed by continuous infusion, rapid onset of action within 2 minutes, early offset of action within 30 to 60 minutes. No dose adjustment is required for renal, hepatic, elderly patient, post-CABG patient, diabetic patient, CKD patients, nothing. Highly bioavailable. That is a very important thing. No drug-drug interaction. This is very common when the drug is a prodrug, like clopidogrel. Clopidogrel is a prodrug. So when clopidogrel acts, it acts by passing through intestine, by passing through liver metabolism. When it gets metabolized in the liver, there are simultaneously, when other molecules in the bloodstream, other medicines in the bloodstream, which are also metabolized to cytochrome P450 pathway. So naturally there occurs a competitive inhibition of that molecule. Plus there is a chance of having a clopidogrel non-platelet, non-reactivity to this such clopidogrel-like agent. So here this molecule has no drug-drug interaction. Highly bioavailable, and you are giving it in an injectable form, bypassing the intestine and bypassing the liver. You give a bolus, and what happens to the platelet aggregation? it drops down to 0 within 2 minutes, and it remains till the infusion is over. And after the infusion, we stop the infusion, the plasma concentration is dropped down in 30 to 60 minutes. This is the best part, because then you need a quick reversible agents also by the time your ticagrelor starts its action. Ticagrelor is a molecule which can be given at 0 minute in the casualty or in the CCU, or it can be given during infusion, or it can be given after infusion. So it does not interact with Cangrelor. The same thing is not true for prasugrel and clopidogrel, because prasugrel and clopidogrel need to be given after the completion of this Cangrelor infusion. So remember this. By the time this action goes up slowly and steadily, the platelet aggregation tendency also increase, but it takes time to reach the significant level, maybe next 2 to 4 hours. And by that time, your other molecules, they start their action. This is the best part of Cangrelor. So dosage and administration, as I told you, 30 microgram per kilogram IV bolus. Remember, this is a 50 milligram vial. It is a lyophilized powder, 50 milligram, which has to be dissolved in 250 ml of either dextrose or normal saline, and 0.9% this normal saline. And that in bolus has to be given 30 microgram per kilogram body weight, followed by an infusion of 4 microgram per kilogram per hour to be given, and continuously to be given either till the infusion is over or till the procedure is over, whichever is the longest. So this is a 50 milligram vial. This dose I am talking of for management of acute coronary syndrome. There is another dosage formulation for another indication, which we will discuss subsequently in the lecture. So 30 microgram per kilogram body weight bolus, followed by an infusion. Immediately after injecting the bolus, within 2 minutes, action starts coming. Within few minutes, the platelets deactivation occurs, and you can safely do instrumentation, pass a guide wire, do the balloon dilatation, and stent with the foreign metallic structure body into the coronary circulation. After discontinuation of Cangrelor infusion, administer clopidogrel, prasugrel to maintain platelet inhibition. But remember, ticagrelor can be used anytime. Clopidogrel and prasugrel need to be used after discontinuation of Cangrelor infusion. Why this is so? Because if you give before, during the infusion or before the Cangrelor infusion, this action of these molecules will not occur, because these molecules act at the same part of the receptor of P2Y12 where Cangrelor acts. And Cangrelor being the faster, it blocks those part of the receptors. There are at least three purinoreceptors of this superfamily of ADP, that is P2Y12. And among those three, the part at which Cangrelor acts, the same part at which prasugrel and clopidogrel act. If Cangrelor acts faster by intravenous route and your oral administration is given, which starts acting after 1 hour, 2 hours or so, and by that time, if Cangrelor has blocked those receptors, your clopidogrel and prasugrel will not have its action. The same thing is not true with ticagrelor, because ticagrelor, though it is a P2Y12 receptor, it acts at the different part of the receptor than the clopidogrel and prasugrel. So you can simultaneously give ticagrelor, which is a potent molecule, and by the time ticagrelor action comes, the Cangrelor action after the stopping the infusion will start reducing. So this is probably the best combination which we can try. And the best part, as I discussed with you many time, our patient, they do not know this. It could be the first episode to the patient. They have not checked their profiles. This is a very common thing. We take the patient to the cath lab, well-off patient, want to do a primary angioplasty. We do the angioplasty, and after doing angioplasty, we come to know that his creatinine is 3, HbA1c is 9, 12, and his hemoglobin is low. He did not have any symptoms in the past, neither he checked in the past. And by the time report came, we are already given with the GP blockers and other masalas. And then we tend to, think of and keep our fingers crossed for the bleeding complications which may face in future, or the contrast-induced nephropathies and bleeding and other issues. But the best part of Cangrelor is, You need not have to wait for the lab. You do not have to go through the report. Hepatic renal impairment, dosage administration is not going to change. You will say, you will discuss with me, or you will ask me, doctor, what is the need of Cangrelor when we have a GP blockers, and which is in India, at least Tyrofaban of multiple companies is equally cheaper. Cost is not an issue. I load my patient with aspirin. I load my patient with safe clopidogrel. I know the clopidogrel 600 milligram is going to have its action in 6 hours. By that time, I will give GP blockers. Yes, you are correct to some extent. There is a fast onset action for both of them, potent inhibition, both of them, rapid offset, no. And if some bleeding complications occur, then you have to wait. This is the reason why GP blockers have gone downstream in all the guidelines in recent past, because of the safety issue. It is not CKD friendly. And nowadays, you are facing more and more patients with CKD. More senior you become, you tend to get more and more complex patients with multiple comorbidities, CKD, COPD, calcified lesions. You need to do rota, you need to do bifurcational stenting, you need to open up the CTOs of post-CABG patient with the bypass was done in 2009 and all those things, So CKD is nowadays becoming, as the aging population is increasing, as diabetic is increasing, as hypertensive population is increasing. Here, GPI is not good molecule. And bridge is uncertain with this. After finishing Cangrelor, you can load with prasugrel or clopidogrel, or during you can load with ticagrelor. The same thing, we are not aware, and together it could be a dangerous weapon. So what is the role of Cangrelor? Yes, this is approved by USFDA. This is approved by European Medical Agency. This is approved by European Society of Cardiology. This is an adjuvant to PCI in periprocedural MI, repeat revascularization, stent thrombosis, patient not treated with any naive patient, means not on any antiplatelet in the agent in the past, patient who cannot take oral tablets, or where the oral tablet is not feasible or desirable because of an unconscious patient or vomiting patients, or patients with no enteral food is allowed in such patients. So efficacy and safety, it was studied in various clinical evidence and various trials. As Dr. Sunil Sathe has told you, this is not a new molecule. This was there as a study molecule for more than a decade together. In 2009, in Brigham and Women's Hospital as Massachusetts, there was a big study of thousands of patients which was carried out, called as a Champion Platform study. The primary endpoints were not met with. And there, something which in the study part, when it was compared with clopidogrel and placebo, the Cangrelor didn't, scored well. But there was, insights after the Champion Platform and Champion PCI, which pave a road for studying this Champion Phoenix trial, which is a wonderful trial, extremely good double-blind trial, where they have not only shown the safety but a remarkable efficacy as compared to clopidogrel. All these three trials, Champion trials, are Cangrelor is compared with clopidogrel. Remember, here the issue is whether 300 or 600, what should be the time of loading of clopidogrel, that is different. Whether the patient was STEMI or STEMI patients are not included in Champion Platform. So their substrates keep changing. There were two studies where the patients were not on any P2Y12 inhibitors. In this study, they have combined STEMI patients, non-STEMI patients, stable angina patients, and multiple, the combinations were done. And fortunately, this Champion Phoenix, this trial, have shown a great benefit as far as the death, myocardial infarction, ischemia-driven revascularization, stent thrombosis. P-value was significantly low. If we take secondary efficacy outcome of secondary stent thrombosis, death, MI, ischemia-driven revascularization, you take all MIs, you take Q-wave MI, you take only ischemia-driven revascularization, you take the death, all these things were, low with Cangrelor arm as compared to clopidogrel arm. So this was, this has made, look at the stent thrombosis within 48 hours. So this is all thing which will lead to, this trial was a landmark trial, and that's why USFDA gave an approval in 2015 after this landmark trial. This molecule was good. Previous studies did not make the end point. That was the reason. But those studies and subsets have clearly shown there was a less rate of stent thrombosis, less rate of death, less rate of ischemia-driven revascularization. But Champion Phoenix has shown that this is a very good molecule. Remember, what are the subsets? You take an extreme elderly population, you take a person of less than 75, whether he is a male or strikingly female. Females, they don't do well with antiplatelets. Here, females have remarkably done well with Cangrelor as compared to clopidogrel. Whatever may be the racial status of the patient, whatever may be the geographical status of the patient, whatever may be the profile of the patient, whether it's a case of a stable, non-STMI or STEMI, he may be low weight patient. He may be a higher weight patient. So same thing is not true with prasugrel. Prasugrel is contraindicated if the patient's weight is less than 60. Whether the patient had biomarker positive, drop positive, or negative, there's a diabetic, non-diabetic, insulin-dependent diabetic, non-diabetic, whether he had myocardial infarction in the past or not had myocardial infarction in the past. Look at this vertical line. Anything which sways more on the left side says that Cangrelor is better, and most of these rectangles are falling way away from the vertical lines on the left side. So this itself suggests that Cangrelor is a extremely good molecule in different subsets, and the same thing is true for 48 hours the outcomes. Whether it is a stroke, TIA, whether the patient had past history of peripheral artery disease, whether the patient is a case of heart failure, compensated heart failure, whether the patient had received clopidogrel or not, whether the patient received bivalirudin, heparin, did you do a 1 vessel stenting, 2 vessel stenting, you put a drug-eluting stent, bare metal stent, you use whatever dose of aspirin you use, and all these things, whether you use GP blocker or non-GP blocker, whatever you do in all these substrates, at the end of 48 hours, a good outcome, favorable outcome with remarkable low p-values were noted with Champion Phoenix study. So this meta-analysis clearly mentioned that this is a favorable molecule as compared to clopidogrel when you are using it for as an second antiplatelet agent. So this is the, what I told you. This is a nutshell of that. So initial two trials, Champion PCI and Champion Platform, didn't make the primary outcome, but this trial, a wonderfully designed trial, have clearly mentioned that the superiority as far as the thrombotic events, and the non-inferiority as far as the bleeding issues are concerned with those all Champion trials were with clopidogrel and Cangrelor. Now we are heading ahead. All the guidelines says that clopidogrel has gone down in an interventional cardiology. As far as the second choice after aspirin as an antiplatelet agent, we use either ticagrelor or prasugrel. Mostly we use a ticagrelor. So Cantic trial, they have used a crush formulation of ticagrelor with Cangrelor, when the ticagrelor was used anytime during the study, and that has shown a significant good result. Cangrelor is as effective strategy to bridge the gap in platelet inhibition associated with the use of ticagrelor. So whatever delay is there, maybe of 60 minutes, 90 minutes, will be taken care by Cangrelor. Ticagrelor can be administered concomitantly before, during, or after the infusion. Cangrelor and ticagrelor combinations offers more than 90% inhibition within 5 minutes. Remember, more than 60, and ideally if more than 80% of the platelets inhibition is achieved, that is sufficient enough for preventing the future event. So more than 90% inhibition occurs within 5 minutes, and mainly it is because of Cangrelor. And effect is maintained for 3 long hours, whereas monotherapy ticagrelor requires 3 hours. I would say crushed formulation will require 1 hour for the action to come. So this was like, this is another interesting study. Like We used GP blockers right and left. Dr. Sathe sir will agree with me that we used, when the physician call us from the periphery that our patient has been thrombolized and still having pain. So we used to say them, let's put him on tirobiban and shift him to me for rescue plastic. So there were number of indications. The patient is having so many other things and patient continue to have non-ST elevation MI, high cardiac biomarkers. Medical management also used to be GP blockers in the past of 48 hours or 72 hours of infusion. But now of late, the indications of GP blocker has gone down because of the increased bleeding complication, maybe because of more potent antiplatelet ticagrelor or prasugrel are there available with us, and maybe because of a good new generation stents which are available. Some of the stents, they need only one antiplatelet for 1 month as far as the study is concerned. And after 4 months, you can safely keep one patient with high bleeding risk for on one antiplatelet agent. So maybe because of all these things, GP blockers have gone down now, and even the guidelines also recommended it as a, I guess it is a class 2A indication or even 2B indication now in ACS condition. So problems which were discussed was in this Cangrelor versus GP study. What they found: major bleeding, more with GP blockers; transfusion requirement, more with GP blockers; vascular complications, more with GP blockers; myocardial infarction, 0% with Cangrelor, 1.8% with GP blocker; total hospital stay remarkably more because of, you know, because of bleeding complications, vascular complications, need of hospitalizations, and less potency. So all these things together, the GP blockers along with aspirin and clopidogrel is not the best as compared to Cangrelor with aspirin and clopidogrel, or Cangrelor with aspirin and ticagrelor, or Cangrelor with aspirin and prasugrel. This now, then if some molecule is hitting the targets, then the research people, they keep thinking the other options of this molecule. And if we want to use this as a more potent, we want to use it as an early action, we want to use it as a safe molecule, we are using it. Then what next? What next means there is this, the molecule has the best part is it is reversible. The blockage is reversible, and if you stop the Cangrelor infusion, the action stops within few minutes. So suppose you have taken a patient for primary angioplasty, you have loaded the patient with aspirin and ticagrelor, and you did an angio and you notice that this is beyond angioplasty and you need to shift the patient to the bypass surgery. Surgeons are reluctant. We always see that. Means I always say that, the way cardiologists are so aggressive, surgeons are never. Particularly, they are afraid in early myocardial infarctions. They are afraid when their enzymes are very high, and they are more afraid if someone is on dual antiplatelet agent. Then what we need to do? You can stabilize the patient medically. Do not give the second dose of thienopyridine derivatives. You start from 2 to third day. You can start with a Cangrelor infusion. Ask the patient to do surgery whenever he is comfortable. Maybe 4th, 5th day, he may be comfortable to perform a bypass surgery. And at that time, approximately study-wise 1 to 6 hours, we recommend to stop it 4 to 6 hours prior to open heart surgery. Stop Cangrelor. Let the platelets to be, fully activated again in 3 hours, and perform an open heart surgery. No much bleeding complications. After hemostasis is achieved, drain put into the the pericardium and this chest thoracic drain, and you restart Cangrelor, and subsequently after completing that infusion, you can reload with aspirin or clopidogrel or aspirin, whatever you prefer after the bypass surgery. This is called as a bridge therapy. This is called as a bridge protocol, and this bridge protocol is one of the new indication, which is because this molecule is relatively p-value is not significant as far as the bleeding complications. Another thing is you do not have to give this dose of acute coronary syndrome in bridge protocol the way we are giving in acute coronary syndrome. Means in acute coronary syndrome, your loading dose and your infusion. Here, infusion is way less. It is remarkably less. It is just 0.75 per kilogram. So it is too less. And you have to just continue for few days till the action of your dual antiplatelets goes off and you can safely take the patient. So this is a single center study, which is again from an European journal, from an American center. And you would see they have used this bridging protocol not only for cardiac surgery, but GI surgery, spine, orthopedics, brain surgeries, where are the surgeries where you have high bleeding risk, you have simultaneously high stent thrombosis chance. If we have done an angioplasty, we have done a bifurcational stenting, we have done a left main angioplasty, we have opened a osteoproximal LED, long stent 48 millimeter deployed few weeks back, and patient comes back to with a spine injury or head injury, or come back to you with some need of a emergency surgery. You cannot ask the patient to wait for 6 months or 3 months till the stent get epithelialized. No, you have to go ahead. In that case, there is a role of such Cangrelor like molecule where you can hold your ticagrelor or prasugrel and start with on the second and third day, when the action of ticagrelor or prasugrel start vanishing off from the bloodstream, you start this molecule in infusion form. After 2 to 3 days, by the time the action of this antiplatelet agent vanishes off, you can do the surgery and save the patient and restart with the antiplatelet as and when required. So this is how the bridge, and what they have noticed surprisingly, ischemic events were less with Cangrelor, bleeding complications were not significant. So in a nutshell, where are we going to use Cangrelor? This is a very important thing. Normal angio, patients spared from preloaded DAPT. Not an uncommon scenario now. We are working for in this last 2 years. We are unfortunately facing problems with COVID, dengue, chikungunya, sepsis. Your hematological system is totally disarrayed. Your prothrombin time is INR is high. Your platelets are low. Patient is in shock. ECG shows some changes. Echo shows generalized hypoglycemia, regional wall motion abnormalities, and your intensivist want to check the angio. If you do the angio, it is possible that if there is a significant coronary artery stenosis of the left main or ostial LED, if you deal with that, patient may improve. But if you do it and if the angio is normal, by that time you have loaded the patient with ticagrelor and aspirin, thinking that it will turn out to be a critical lesion. If it doesn't happen, or if there is only a thrombus, and if you are loaded with the patient with DAPT, then that DAPT will remain in the bloodstream for next 3 to 5 days, and with a low platelet, that could be an issue. The same thing is there with certain misleading ECGs. In spite of practicing for 25 years now, sometimes the ECG, significant chest pain, we do not have previous ECG. There is a LBBB, echo shows paradoxical motion and some sort of an hypokinesia of LED territory, and we tend to take the patient to the cath lab. We do not know whether this LBBB is there, which is usual ECG, or the LBBB is there because of ventricular infarction. Same thing is there in pacemaker patients. Same thing is there in WPW syndrome. So all these patients, this DAPT can be saved. It is very important in clopidogrel resistant patient. We all know in India, there are a lot of patients with clopidogrel non-reactivity, hyporeactivity, platelets reactivity is less, and stent thrombosis, which we used to face in the past. Dr. Sathe sir will agree with me at doing a very crisp, clean angioplasty in midnight hour. If intensivist call us that patient is again having a chest pain and ST elevation, that was not an uncommon scenario. After doing 100 plasties, we used to face 1 or 2 such cases, in spite of doing best results, best pre-dilatation, post-dilatation, and giving clopidogrel in a proper dose. Because it is the patient's platelets were not reactive to clopidogrel. It's not related to your, technique as such or your skill as such. But we used to face the brunt because patient relatives say we have paid good amount of money for this angioplasty and still the stent has got failed. So clopidogrel resistant patient, yes, Cangrelor is the best drug. If you are going for a bypass surgery or non-cardiac surgery, you can use this as a bridge therapy. GP blockers, bleeding is a major concern. I would not agree with the cost because tirofiban of Indian companies is equally less costly or maybe little less costly than Cangrelor presently. I am sure the company people will bring down after increasing the uses of Cangrelor, subsequently bring down the cost of Cangrelor. Benefits are sustained up to 30 days in the trial when we use complex PCIs which require hemodynamic support. As I discussed with you, there is a role of, there is an intuitive role where we can have a better antiplatelet action, better platelet blockade in the initial phase when we are deploying multiple stents. Sick ICU patients where you cannot give oral treatment, stent thrombosis is almost rare with Cangrelor. Timing of clopidogrel, there are a lot of issues, when to load, when the action comes, 30, 100, 600, we do it with 600, but timing is an issue. Bivalirudin, I myself use bivalirudin hundreds of time. Original bivalirudin as well as bivalirudin of Indian makes generic bivalirudin. But of late, for last 4-5 years, we have stopped using the bivalirudin because somehow this molecule, to some extent, it's my experience, there is an increased chance of stent thrombosis. Indian people, they are more prone for ischemic events and the thrombus burden is high. The vessel caliber is less. Disease is diffuse. More diabetes is there in Indian substrate. Here, as compared to US and European population where they are using bivalirudin more frequently, I interacted with many international KOLs in various meets about bivalirudin. You also used it, but we do not, we cannot afford to have once a while stent thrombosis during the procedure or immediately after the procedure as compared to heparin. We are happy with heparin. So heparin, aspirin, ticagrelor and cangrelor would be a wonderful combination. There is an unmet need. Why ticagrelor? As I discussed with you, prasugrel has a lot of limitations. You cannot give it in a doubtful history of TIA. You cannot give it in past history of CVA. You cannot give it in less than 60 kg of man. You cannot give it in more than 65 years of person. You cannot give it unless you do an angiography. So that is the main problem of prasugrel. You have to do first an angiography, and you are talking of primary angioplasty. You are trying to match the door to balloon type. So here the prasugrel is out of question. So we have to use ticagrelor, we have to use aspirin. You decide when to use ticagrelor and go ahead with cangrelor, and that is that will solve most of the purpose of your interventional this. We are fortunate to use ticagrelor for the first time in the region of Marathwada. Actually, when I went to I have a habit of going through the literature of all new molecules which are coming on horizon. Whether it is lercanidipine, whether it is a pravastatin in the past, whether it was a dabigatran, rivaroxaban. I used to deliver a lot of lectures on these newer molecules, Arni, Dapa, Amiodarone way back in 1998, 99. But I was thinking that this is a good molecule when some person will come to me with an unconscious state where I have to use it for the first time. I have to be, very, very cautious and very practical where I cannot use ticagrelor in that. So this was the case. It was morning at around, this was on 13th of November. It was in the morning hours at 9 o'clock, 9:30, we were taking rounds and we received a phone call from the casualty that a young patient of 41 years is being brought to the casualty. He's in severe agony and he's having hypotension and ECG recorded, and that is showing an extensive anterior wall infarct. There is no relative of him. There are colleagues who has brought him from the company to the casualty. We asked him to shift to the cath lab. We thought that we will discuss with the patient's relative regarding the option of PAMI. If not, then thrombolize and then subsequently think of either rescue if the symptoms continue, or then next day take the patient to the cath lab. So while shifting from the casualty to the CCU, when the patient came to the CCU, few relatives also entered into the CCU. I, angrily said them, you go out, we will discuss with you, let me see the patient. And the patient was very well conscious, absolutely conscious, talking at that time. He was in agony. Relatives went out of the ICU. Once they went out of the ICU, patient, while shifting from the stretcher to bed in the CCU, he arrested, he convulsed, he had a VTVF. He was about to fall when ward boys picked him. We also helped them. Patient's relative were outside at that time. It's very difficult to tell them later on that immediately after you went out, the patient arrested. So we resuscitated him, gave DC shock, defibrillate twice or thrice. Then meanwhile, ambo bagged him, and he started getting, he was confused, but he was awake. His ECG showed massive ventricular infarct. The rhythm started reappearing. Meanwhile, we called the colleagues. There were no relatives, actually, colleagues. And then we showed him that this and this thing had happened. Now he's okay, but we have to take him emergency for an angioplasty. There was no point in putting the Riles tube. We did not know what has happened when we, massaged him vigorously to the ribs. And so we just started with an Cangrelor, and he fortunately at the physician's side, he has received tablet aspirin there. So we took him to the cath lab, did the angioplasty within next 15-20 minutes. At the end of angioplasty, his orientation started coming back. And then he was asking, where is he? And when I asked him the question, is he having a chest pain? He's saying the pain which was there at the rib, which we did the vigorous resuscitation. So this was the first case which we used, where there was no other molecule at that time which I should have thought of using when Cangrelor was available. You will agree with me with this kind of a scenario. This was the second case. This was again in the afternoon hours when we were performing. One cath lab was busy, and second with a chronic total occlusion. And the second cath lab, we were taking out the patient from an angiography. It was just done. And when the patient was being shifted, we received a call of an anterior wall infarction. We loaded the patient with aspirin and ticagrelor and immediately prepared him. The system was upright. So in the afternoon hours at around 3 o'clock. So by the time we took the patient into the cath lab and took the shoot, we noticed that there is only 15 minutes are passed after giving aspirin and ticagrelor. So we started with a Cangrelor and stented the patient. This was the third patient where the similar thing, where it was in the, again in the morning hours, where we did the primary angioplasty, where the door to balloon time was less than 20 minutes. So though the ticagrelor was given, we were not sure whether the action was going to be there or not. So we used Cangrelor. This was on the 11th December. This is on 20 December. This was a VIP person, close family friend of my colleague cardiologist. We did his primary angioplasty, 20-year diabetic and 20-year hypertensive. We did his primary angioplasty of RCA 5 years back. He was on ticagrelor 4 years back. He was on ticagrelor 90 milligram and subsequently 60 milligram for 1 more year. And then we switched over him to aspirin and clopidogrel. This was normal at that time. It was absolutely normal. So once this was in the night hour. This was something around 9:30 or 10 o'clock as we were informed. So cath lab members were all there. So immediately within next 15 minutes, that is our usual protocol. So we took the patient to the cath lab within 15-20 minutes. We already started with Cangrelor in the CCO only this time. My colleague cardiologist and a competent person who is associated with me for last 12 years, he naturally put a wire. Versatile wire is our usual guide wire, which we use a soft tip, not much penetrating power of this wire, and it is non-traumatic, I would say, less traumatic. Naturally, our guess was the artery is like this. So the wire went in, did the balloon dilatation. The wire was not going in, so we made a loop and then pushed it down, thinking that LED is like this. So artery opened, and then we noticed there was some flow here. So we came to know that no, artery is here. Took out the wire from that place, put a wire here, stented this, good flow occurred. Patient was happy. We discussed with the relatives. It is our usual protocol that after doing some complex plasty, we do not shift the patient for next 15 minutes or 20 minutes from the cath lab table. Because there are some, 1 in 100 times there's something happens in such patients. Keep them on table. Meanwhile, you can discuss, you can see some OPD, you can talk to the relatives, you can prepare the notes or post-cath orders, etc. We started noticing that 90 heart rate increased to 100, 100 to 110, 120, 130, and the blood pressure started dropping 80, 90. Initially, we thought there is something, is there a vasovagal, is there something happening? It was all radial route. So the chances of femoral bleeding or all those things were unlikely to be there. We checked the radial, everything was okay. So, what could be the reason? Then we went through the frame by frame and we noticed that there was a small perforation which has occurred at this branch where the soft tip wire went. So, this, like we use this workhorse wire for last 7-8 years, or 5-6 years since it is available from Abbott company. The wire has no fault as such. Still, we are using it 100 times in a 70-80 times in a month. This is our workhorse wire. It was the coronary perforation which has occurred because of the strong antiplatelet action together with ticagrelor and cangrelor. And when I went through the literature, I noticed that coronary perforations and dissections are more common, though it is not the side effect of cangrelor, but they are noticed to be more common with cangrelor. In such situation, discontinuation of the cangrelor is the treatment of choice, and deal with the perforation if it is significant. Here, perforation was significant. Patient was sinking in front of us in spite of having a good result. So we passed a wire through the stent struts, so which was not easily going. Then the balloon dilated here, then wire went there. Then after going, wire went there. We tried to do a controlled balloon inflation here, prolonged balloon inflation here. It didn't work. Once we took out the balloon, again the perforation started leaking. Then we tried for a controlled dissection at that part, but it didn't work. So ultimately at 11:30 in the night, we decided to put a stent graft here. So we know stent in stent could be a little problematic in future, but right now it was necessary to save the patient and sacrifice the bleeding branch. So we sealed this branch itself and sealed that, helped the perforation to be sealed. We observed the patient. Subsequently, the pericardial effusion was mild. Next day morning, the pericardial effusion not increased, the branch was sealed. Whatever minor STT changes which occurred because of diagonal occlusion in one AVL disappeared subsequently, and that artery was medically managed. This is now more than 1 month. He came for a follow-up also once, and he's doing very well. So this, some things which we need to happen. If you go through the literature, out of the 10,000 patients of used in double-blind study with Cangrelor as compared to clopidogrel, they have also mentioned 270 patients of Cangrelor group had some major bleeding, is as compared to 170 of clopidogrel. So 175 of clopidogrel. So 175 and 270 may not, p-value may not be significant, but there is a little increased risk of bleeding, and that we have to keep in mind. If you are using a more strong weapon, you are compromising the safety. So to some extent, so that you need to be careful. You need to be, the way we use our wires in CTO, we have to be careful. I would say next time onwards, we'll be careful. While using Cangrelor, we will be taking care of the small branches also. Though it happens once in a blue moon, but when it happens, you have either once you have happened it, you have to deal with it. You have to rectify the problem which has happened in the cath lab. That cath lab complication needs to be treated in the cath lab, one thing. And second, you have to be more wiser subsequently when you are using this molecule. So as far as the this MSN is concerned, I visited MSN center. I can proudly say this is an extremely good scientific outlet which is available at Hyderabad. I was there for 3-4 hours. It's, I like to see how the molecule is generated, prepared, manufactured, what are the, these particulates which they use, how the study is being carried out. I was there for 4 or 5 hours. It's wonderful to visit that center. It's proud that this company is an Indian company. Let me tell you, the most of the rosuvastatin in India is prepared by, the raw material is prepared by this company. You might not be knowing this fact, but most of the companies, rosuvastatin raw material is prepared by MSN. This MSN has good share in pulmonary hypertension management which we all know, and Cangrelor is something which is a great development, which great molecule which MSN has produced. And thank you very much. This is all what I want to say about my experience of Cangrelor, about the review of literature of Cangrelor. So this is a molecule one should think of in interventional cardiology, in a bridge therapy, when we are in a doubt of antiplatelet agent, when we do not want to give dual antiplatelet agent, when we are not sure about the coronary anatomy. These are or when the patient cannot take oral medicine because of some or other reasons. So these are the things where we should use Cangrelor. And my colleague cardiologist in Marathwada, after my first case, have also started interacting with me very often that what should I do in such case, whether I should use it. And they are also now using it. Now we are a team of 50 cardiologists in Marathwada. So it's a big, in Aurangabad, and maybe 100 in Marathwada. So it's a big community, and it's a big blessing for the patients to have such molecule when we are treating acute coronary syndrome. Thank you. Thank you very much.
Thank you, Dr. Magarkar. I think that was a very, very good, crisp, and very, very clear talk. I must compliment you for this excellent talk, because it's a new molecule. And honestly, I have not used it. So I think your experience enriches all of us and gives us more confidence to use it, actually. And a few points of discussion, which I would like to take your opinion. First is, so many of our patients are, say, we have done an angioplasty several years ago. They are on a combination of aspirin, clopidogrel, and now they come with a second artery infarct. So suppose somebody is already on, if it's only aspirin, it's okay. But suppose somebody is already on clopidogrel aspirin combination, then with a PAMI for the second time, second artery, can we give Cangrelor, or what should we do?
Sir, if he is already on an antiplatelet agent and the clopidogrel is already on the board, still the platelets are active and still the thrombotic event has occurred. So we will forget about the whatever clopidogrel action is there in the bloodstream or not. We should take it as a fresh case. And if it is a fresh case, then we should use Cangrelor if you have to match the door to balloon time. If you are taking it little later, you can give ticagrelor in such situation. But we should forget whether what were the patient taking clopidogrel, because clopidogrel is already there, and with that clopidogrel, a new thrombotic event has occurred.
Okay. Second question is, see, we don't do a lot of PAMIs as you people do there, because we do. It's not that we don't do. But suppose we are doing a complex angioplasty. So in such a patient, can I patient is, we have started, say, ticagrelor 2-3 days ago, and now we're doing a complex plasty. Can I use Cangrelor electively, thinking it's, I'm going to use a multivessel angioplasty, 4-5 stents? So what is your take on a elective angioplasty, not a thrombotic PAMI?
No, sir. It is actually when you are already on aspirin and ticagrelor, platelet non-reactivity is almost not known. So your patient is already loaded with ticagrelor, is on and continuation doses of ticagrelor. I don't think any role of Cangrelor as an additional antiplatelet agent in such scenario, because your P2Y12 receptors are already blocked with ticagrelor. So there is no need of giving an additional P2Y12 inhibitor in such cases. It will be like just giving ticagrelor, aspirin and clopidogrel together, or ticagrelor, aspirin and prasugrel together. There is no role in elective angioplasty with Cangrelor. You can continue with your usual heparin, aspirin and ticagrelor and do the angioplasty.
Okay, good. One more common question is, suppose we have an unstable angina patient.
Yes,
somebody, a physician has already given him ticagrelor for a day or two, but when you take him for the lab, it's not PAMI, but we know it's, unstable angina, thrombotic situation, where otherwise I would like to use a GP2B inhibitor. So many times we think, no, it should be given, so we give GP2B, which is quite commonly used, as you know. So in such a situation, though the patient is on ticagrelor and we know it's an unstable angina, thrombotic situation, can I give Cangrelor?
No, sir. Here also, the platelets are being taken care as far as the receptor part, purinoreceptors of P2Y12 is considered. They are being taken care by ticagrelor. So if there is a visible thrombus, which we are afraid of, and if we want to take care of thrombus, which is less likely to be dealt with thrombus aspiration catheter, then here we can use GP blockers. With presence of ticagrelor and prasugrel, we are using less and less GP blockers. But the such situation come in offer in our clinical practice, that patient, we are loaded with that patient is taking it for 2 to 3 days, an unstable, vulnerable plaque, and we are dealing with it. Here you can use a GP blocker. Here again there is no role of Cangrelor in such situation. I don't find any role of Cangrelor as an additional thing, as an antiplatelet here.
See, what has happened is, that's why I'm asking you these questions, because after Cangrelor came, I really wanted to use it, but what has happened is, in our practices, either patients are already on ticagrelor, or most of them are loaded by a physician with, say, 600 clopidogrel, and they come to us. So that is why somehow we never found, because our PAMIs are on the lower side.
Yes, sir.
Our use of Cangrelor really did not pick up, because everybody is already on either ticagrelor or fully loaded with either prasugrel, or they should not have loaded with prasugrel, but at least clopidogrel. So if somebody is loaded with clopidogrel, even in a palmy situation, you cannot use Cangrelor, isn't it?
Yes, sir. If it is already loaded and the loading duration is crossed the action of platelet activity, then
Correct.
there is a no role actually.
Correct. So if a patient, as your cases were clearly shown,
Yes,
they
sir.
come with a palmy high risk situation, no past history of any anti. See, that is the main problem where, I was talking with MSN that, that was that subset has suddenly dropped in our practice, where, there are a lot of palmies going on. I'm sure I would like to use that. But otherwise, that's why the potential for this good molecule is sort of lower side because of the type of practice which we are following. Because
Yes.
everybody is already on dual antiplatelets, fully loaded with either of these two, and that is why in such a situation, that is a problem. The one more question I would like to ask you: suppose you are doing a PAMI, forget this situation; it's a proper PAMI.
Right, sir.
So in the casualty, once the patient says yes, can you start Cangrelor before you take him to the lab?
Yes, sir. In fact, this is the perfect indication whether the patient, this is the perfect time where you can start Cangrelor, because the action will start early. You load the patient with aspirin, you start Cangrelor. It has been said nowadays that, I was listening through the YouTube lectures at some regional centers of Cangrelor last night. They also mentioned that keep the Cangrelor in casualty.
Correct.
What will happen if your patient, they are in a dilemma whether to do go ahead with the PAMI or go ahead with the lysis? You start with a Cangrelor and you shift the patient to the CCU, start preparing the patient. If the patient says no, you can stop and you can think of other option like thrombolysis after a few minutes, or you can think of medical managing. And then if you say yes, then Cangrelor is already on the board and you can continue with Cangrelor and do the angioplasty. And before coming out, you can start with a ticagrelor and have the that gap which is fulfilled of vanishing of the action of Cangrelor and picking up the action of ticagrelor.
Correct. But is there any data that you have stopped Cangrelor and have given lysis? Because, if somebody bleeds, that is the problem.
No,
so
sir.
unless the patient is sure,
yes,
I think because if somebody bleeds, then they will blame Cangrelor for the bleeding.
Yeah, it is a weapon which is a strong weapon. But anyway, 30 to 60 minutes is the time of action goes off of Cangrelor from the bloodstream.
Correct.
And we can very well thrombolyze the patient within 6 hours. So if the patient reaches within 30 minutes, then you can start Cangrelor, load with aspirin, stop it. After stopping, you can give clopidogrel and you can thrombolyze the patient after 30 minutes.
Because I always thought that was a point to learn. I always thought, because see, if you are doing any other type of plasty except PAMI, that means currently according to you, there is no indication for Cangrelor and except PAMI, and that too when the patient is not loaded, correct?
Yes, sir.
So this is very important for people to know.
And bridge therapy, sir. Bridge therapy is there. Like you have done the angioplasty patient, recently, and patient is going to go for a major cardiac or non-cardiac surgery. Then you are afraid of switching off the potent thienopyridine derivative. There you can hold it on, start with an Cangrelor, go ahead with the surgery, restart with Cangrelor, and at the end of infusion, load with the second antiplatelet agent.
Correct. But that's a rare situation. I mean, for us, main thing is interventional. And that is why the interventional subset, that is what I was discussing with MSN, that the subset becomes very small in our practice, depending on where you are practicing and what type of interventions you are doing. Say where rubeol is doing majority is elective.
Right.
There, the total volume of work becomes very less for Cangrelor. I mean, that is what I was just discussing.
Another theoretical indication when we are in a dilemma, and there could be a relative contraindication in view of bleeding tendencies or low platelet count, fever, sepsis, and we are in dilemma on ECG and echo, even on cardiac enzymes, whether the coronary artery diseased or not. So rather than loading with clopidogrel or ticagrelor, we can start with the Cangrelor, do and check angiogram, and within few minutes we come to know whether there is a disease or not. If not, then stop Cangrelor immediately after 5 minutes and come out of the scenario. That is one theoretical indication.
That's a good indication actually. Perhaps more commoner, where you are not sure, plus minus, give this drug. At least you are safe that patient will not infarct. That would be a good learning point actually. Any other issues to be discussed?
With your kind permission, can I put in some questions, sir?
Yes. Now. I want all the panelists to come in. Yes.
Yeah, sir. Dr. Rajiv Girdhar from Bhiwani is asking one question, sir, that if failed thrombolysis by outside, but if we will do primary PCI, what is the good role of Cangrelor about in post-thrombolysis patient?
Yeah, the rescue plasty, this is a rescue plasty. It depends upon the duration of thrombolysis, a duration of platelet loading. Patient is thrombolized outside, patient is loaded with aspirin and clopidogrel outside. The usual practice which we follow in such situation is reload, forget about the clopidogrel, reload with the crushed ticagrelor 90 milligram, 2 tablets, and take the patient for angioplasty. This is sufficient because already the aspirin and clopidogrel is already there on the board. Patient is already thrombolized. In a thrombolized patient, if you give another agent which is with an adequately blocked platelet, you can say if the percentage of platelets, though the thrombus is not being taken care fully as you are taking the patient for rescue, but the platelets are not fully, in such situation, you can reload with ticagrelor, forgetting about the clopidogrel loading. Already few hours have passed and take the patient in next 30 minutes for rescue plastic.
I think one more very much similar question, sir. What is your opinion about Cangrelor as a bailout drug? When we have not planned to use it, which situation it may be helped us to bail out?
In fact, our second and third case was a bailout case, I would say. We have loaded as usual. See, 6 months back when the molecule was not there with me, I would have loaded with aspirin and ticagrelor, did the angio, huge thrombus. Either I would have used GP blocker or I would have continued with the angioplasty and watch whether there is a slow flow, no flow, how is the TME flow after stenting. Use the aspiration, thrombus aspiration if required. Here, in second and third case of mine, where the ticagrelor and aspirin was given, but the door to balloon time was so quick because those were working hours, and within 15-20 minutes we took the patient. So it was a bailout situation. Like after loading, after doing angiography, before passing the guide wire, we thought better to give Cangrelor because this will help to block the platelets. So by the time guide wire was passed, the Cangrelor bolus infusion was given by our anesthetist. So that helped to deactivate the platelet. So this is like a bailout situation, I would say.
Correct. So the bailout, actually what people should know is the time. So when your time is insufficient for the antiplatelet activity, you must give Cangrelor. But what question was asked in a routine patient where a patient is already loaded with clopidogrel post thrombolysis, I think then Cangrelor has no role to play.
No.
Correct?
Yes, sir. Yes, sir. True.
In a simple line, one question has been asked by Dr. Badri Danpani from Berhampur, sir. Can we think Cangrelor as a replacement of Tirofiban?
Actually, Cangrelor is an antiplatelet. Tirofiban is an antiplatelet, and Cangrelor should be used to, aid in an acute situation where we are not sure about the antiplatelet action of the ticagrelor or prasugrel. This is bottom line. This is a very, very clear bottom line. As of now, we are not using Cangrelor as a molecule in medical management, in ICU management of non-STMI. We are using it selectively in percutaneous PCIs only, and it is definitely not a replacement of GP blockers, but it is found to be superior to GP blocker in PAMI because of good action as well as more safety, less bleeding complications and reversible obstruction. But it is not the drug to be used in intensive care.
Correct.
In fact, I think you have already answered this question, but many of the chat box I could find out that why only Tirofiban, why not clopidogrel and prasugrel as a switch on from Cangrelor from Tirofiban? I think you have already answered that mechanism of action on this.
This is actually a very important. I have also got the similar query from cardiologists from Solapur, cardiologists from Miraj, that what happens if I load the patient with clopidogrel early, and why after the discontinuation? The receptors, there are lesions, there are points where the receptor parts are there, and those parts are blocked with Cangrelor, and the same part is being targeted by clopidogrel and prasugrel. These both are prodrugs, and they act at the same part rather than ticagrelor, which act at the different part of the receptor. So when this thing happen, so action of those molecules, it's a waste of giving those molecules because they are not, they are there in the bloodstream and they get dissolved. They are not working at the platelet. So you have to either reload it, forgetting that. So better not to give that. And ticagrelor can be given at any time because it acts on the platelets at a different site of the similar receptor.
Correct. Me, actually, if you reload within that time period of Cangrelor action, it's a waste. So you have to reload.
Yes,
so which is a waste. So either you wait properly and do it at the right time. The time is important.
Yes. After
so actually, if you really see Cangrelor, the whole thing is timing. The real indication is timing when you want to go fast and when you have given antiplatelets. And even after you give, the timing is important.
Yes.
So I think unless you give ticagrelor, so I think it's an interesting molecule and we must use. Any other questions, Nitin?
Sir, just one more. That is the uses of heparin along with Cangrelor.
It has to be used. It has to be used. See, heparin is something which we use. Either you use heparin or bivalirudin during angioplasty. We use heparin. We have used bivalirudin hundreds of times in the past, maybe 300, 400 times in the past. But nowadays we are not using it. Somehow the availability in India is also less. We are selectively using it in certain substrates where there is a high bleeding risk, where we are using bivalirudin. But otherwise, heparin to be used in angioplasty because we are doing instrumentation. It is an anticoagulant which is adding to prevent thrombus formation during instrumentation of coronaries. We are tackling the coronaries. We are tackling the angry fissured plaque, angry platelets, thrombus which is there. So heparin is mandatory. Without heparin, we should not enter into the coronaries.
This is all about, sir. I think all the questions have been answered already.
But Nitin, I think with this, I think I must compliment Magarkar for a very excellent review and a good talk and a good perspective because he has used it also. But see, when we are actually, when MSN is going to cardiologists, these only 2 points are important. You give us those pamphlets, where there are so many indications of bridging. In bridging, that's okay. But if you see the pamphlets which you give, complex plasties, angiographic things, so many other people think that in a complex plasty you should use Cangrelor, people can be mistaken. So what Dr. Magarkar said, the 2 points of time, inadequate time, and afterwards the time after, that is to be stressed. And that is extremely important for all of us, I think, because otherwise, we will think that this is an antiplatelet, potent antiplatelet just to be given in a very complex situation of left main bifurcation, which has nothing to do with that. So that is what, you must also stress when you go to cardiologists, Nitin.
Surely, sir.
Just one thing, if just last Magarkar sir has said something and it came in my mind that as an emergency condition, once we are loading this with the tirofiban and clopidogrel, but you have asked already, sir, Sathe sir, that can we start the using of this Cangrelor as a loading drug, and can we put some places across India that this injection as a emergency place where exactly the patient is coming over there and the loading is happening over there?
No, you must. But what Dr. Magarkar said, that the patient has to be ready for a PAMI.
Yeah.
I mean, if you are otherwise, see what happens is, if you are going to thrombolize, then I am not comfortable because if somebody bleeds after that, you have to wait for that time and something goes wrong. There's no data. So if the patient is ready for an angioplasty, yes, it should be given in the casualty, as Dr. Magarkar said.
In fact, there are certain reports, Nitin, there are certain anecdotal reports where indirectly they have said that Cangrelor should not be used before or after thrombolysis.
Correct.
This is what Dr. Sathe sir was pointing
out. Correct.
We will come to know about this molecule. More uses will occur subsequently. We are, we will, our patients are our best teachers and our results are our best teachers. So we, when you start using it, you tend to know certain minor complications. You tend to see some problems. You tend to see some advantages. Subsequent horizon can be expanded of the indications also. This is going to happen. And one thing is very clear, that this is the first intravenous antiplatelet agent to be used along with aspirin. I would not say GP blocker as an antiplatelet to be used along with aspirin. Only antiplatelet, I will say. So this is the first intravenous thienopyridine derivative which is used along with aspirin. So this is the first advantage. Second, when the patient is unable to take orally, there is no other way because of some or other reason. Third, oral intake is not enough to get absorbed because of systemic problems, like some patient is of malignancy on chemotherapy, multiple drugs, or there is some enteral preparations are not allowed, patient is unconscious. These are the things where you should think of this molecule. This is not an situation coming often in our practice. The way your practice goes senior, as I told you, you tend to see all such kind of a patient, tertiary stage 3 malignancy, patient is in agony, severe chest pain, hemoglobin is 7-8, is already on a chemotherapy, incision has been taken somewhere recently, patient is having extensive infarct. You cannot say that I would not treat this infarct with an angioplasty. So here, you have to be rational, logical in managing such patients.
Yeah, I want to ask last question to Magarkar.
Yes, sir.
Recently, we had a situation. I did a complex left main plasty, 4 stents, and patient left within 3 months had to go for a pancreatic surgery, which had to be done. Now you have to stop antiplatelets, put the patient on Clexane, all that. So with Cangrelor, is this the bridge you can use Cangrelor? I don't know. I mean,
Yes,
when
sir.
you
Yes,
stop
sir.
this,
Yes, sir.
but what time do you? I mean, when do you stop? When do you start?
Yes,
Suppose
sir.
today I stop both the antiplatelets. When do you start Cangrelor? What is the format for that?
Sir, there is a classical recommendation what they have mentioned. You have to continue with aspirin till a day prior to surgery. You stop ticagrelor, within 2 to 3 days, ticagrelor action starts coming down. So from second or third day onward, you start Cangrelor. On the 5th day in the morning, you stop Cangrelor infusion. In the afternoon, within 4 to 6 hours, operate the patient. In the evening, once the hemostasis is achieved, you restart Cangrelor infusion. At the end of Cangrelor infusion, after 2 to 3 hours, reload with your ticagrelor and aspirin and continue that thing. This is absolutely the same indication.
Correct. No, correct. But only thing is, so here, because they wanted even aspirin out for 3-4 days. So can I start Cangrelor 3-4 days prior?
Yes, sir. Aspirin nowadays, this molecule is a quite senior molecule, but over a period of time, we are now stopping aspirin within 1 month also after angioplasty, and as per the trials which are done at Samim Sharma's center, within 3 months also. So aspirin can be stopped if required. And ticagrelor can be stopped, breached with Cangrelor, restarted with ticagrelor after the infusion is over, after the surgery, and add aspirin subsequently. May not add aspirin because we have noticed that ticagrelor is not the thing which is producing more bleeding complication. It is together with aspirin is more bleeding, produces bleeding complication.
Absolutely. Because this is an important indication which people should know, and is not uncommon, especially complex plasties and non-cardiac surgery.
Yes, sir.
Over to you, Nitin.
So thank you so much, sir. I think all the queries have been very much handled, all of sir. So on behalf of MSN Labs Private Limited, my heartfelt thanks, gratitude, and respect to both our distinguished faculties for not only sparing your precious time to grace us this occasion, but also for enlightening us with your today's commendable talk. And thanks again for clearing concepts and enhancing our understanding about the novel antiplatelet therapies and the use of Cangrelor. And my sincere thanks to all our audience also for sparing your valuable time with us to grace this occasion. Thank you so much, sir, from our side.
Thank you.
Thank you. Bye-bye. Thank you.
Thank you.